Good morning all, and thanks organizers for the opportunity. I think my topic has been discussed already in extensive mode from yesterday to now. Then again, recap. So nowadays if we are talking about the first line chemotherapy, then I think this is the era of immunotherapy. The better name will be first line treatment, I think. So we are going to discuss that this is the small cell lung cancer. I think we have discussed the high grade neuroendocrine carcinoma with this metastatic potential, 3-year relative survival rate 10.7% till 2015, and mortality has declined since 2001 largely due to decreasing incidence rather than treatment advances, and most common genetic alteration was 53 RV1 inactivation, no clear targetable genetic drivers. So we have discussed this limited stage and extensive stage in last two presentations. So what are the options except that immunotherapy of etoposide cisplatin? I have seen that it is good in limited stage also as a concurrent chemotherapy, as a neoadjuvant therapy, and as a metastatic therapy. And 3 drug regimens were not so good in improving survival, and they were causing the more toxicities. So we were stuck to only the etoposide cisplatin. Then immunotherapy came into the picture. What is the rationale to combine immune checkpoints inhibitor with chemotherapy? The chemotherapy induced tumor cells killing may induce tumor antigen release and exposure to immune system. That PD-L1 overexpression leads to the immune cell evasion and T cell inhibition. And PD-1 or PD-L1 inhibition restores tumor specific T cell immunity, or reversal of immune suppression leads to deeper, more durable systemic anti-tumor response. However, all the immunotherapies are having maximum response rate 25% alone. This is the overview of key studies of immune checkpoint inhibitors in small cell lung cancer. First was the ipilimumab, then came to the nivolumab plus ipilimumab keynote 028, then pembrolizumab, atezolizumab, nivo-IP, and so on till last pembrolizumab in 2020. So this was the phase 3 trial, that addition of anti-PD-L1 checkpoint inhibitors to first line platinum plus etoposide in extensive stage small cell lung cancer. These patients were stratified according to the sex, performance status, and brain metastasis, yes or no. Patients with measurable extensive stage small cell lung cancer, no prior systemic therapy, and treated or asymptomatic brain mets patients were eligible to be enrolled in this study. Treatment regimen was induction with the carboplatin plus etoposide 4 cycles plus minus atezolizumab or placebo, and then maintenance was the atezolizumab maintenance or placebo maintenance till progression at that time. But nowadays we are capping at the 2 years immune checkpoint inhibitors. Co-primary endpoints were overall survival, PFS by investigator, secondary endpoints overall response rate, duration of response, and safety. By side we are keeping with the Caspian trial, that because always we are confused which to be used. That is stratified by plant carboplatin versus cisplatin. In this was also in first line setting in extensive stage small cell lung cancer with good performance status or asymptomatic or treated. Population was nearby same. With the induction was same, that although this was a 3-arm study, the durvalumab plus trametinib plus EP, or durvalumab plus EP or EP. So maintenance was durvalumab plus trametinib. It was 4 weekly in maintenance setting, and then durva 4 weekly or placebo optional. With prophylactic radiation was optional in this case. So primary endpoint was overall survival, and secondary endpoint was progression-free survival, response rate, safety, tolerability, and patient-related outcomes. So we are going comparison slide by slide always. That one is the Empower 133 and Caspian overall survival. That we can see that there is a median overall survival nearby same both the trial. However, we cannot control because of the trial design and etc. But yes, for our practical purpose, we should compare these two trials. So median OS nearby same 12.3 or 12.9 versus 10.3 month. So that means the control arm was adequate in these two studies and well designed. So and hazard ratio 0.76 and 0.75 nearby same. Again 1 year overall survival is 39 versus 51 and 18 month it is 21 versus 34%. Same nearby in Caspian also. At 3 years, there is data is not available. I think for this, it is around 22%. We will discuss in later slides in M power 133 and nearby same in this also Caspian. Again, so table form of discussion that blinding atezolizumab trial M power 133 double blind. This was open label. Performance status, they took ECOG and the WHO, but good performance status patients. Brain mets allowed treated or asymptomatic in Empower 133. In Caspian, asymptomatic or treated and stable off steroids and anticonvulsant for more than 1 or more month before study entry. So no active brain mets. Platinum agent, carboplatin. And in Caspian, they allowed cisplatin also. Dosing frequency at Empower 3 weekly, but in Caspian during induction it is 3 weekly, and in maintenance it is 4 weekly. Number of chemotherapy cycles in atezolizumab both arms were having 4, and in Caspian they allowed in control arm 4 to 6 cycles, and durvalumab arm was having 4 cycles. PCI permitted during maintenance in Empower 133. Durvalumab arm did not permit for the PCI, and control arm was permitted. PDL1 status in both the trial did not correlate with the response in small cell lung cancer. That's why we are not advocating for the PDL1 testing in small cell lung cancer. This was another trial, checkmate 451 nivolumab plus ipilimumab versus nivolumab versus placebo. So in this trial also maximum 4 doses were given of ipilimumab, and nivolumab 3 weekly was continued even after the induction, and second arm nivolumab to 240 mg 2 weekly or placebo. So primary endpoint was overall survival, secondary endpoint PFS, and other primary endpoints. So no OS benefit with maintenance Nivo plus EP was observed with a hazard ratio around 0.92, not so good, and median OS was 9.2 versus 9.6 months. Frontline chemoimmunotherapy in small cell lung cancer. So this is a forest plot. We can see in Power 133 hazard ratio 0.70, Caspian 0.75, total is 0.73. PDL1 acrin 516 and nivolumab, or PD1 anti-PD1 604 pembrolizumab, hazard ratio 0.76, and CTLA4 0.90. PDL1 and PD1 agents are similarly effective in small cell lung cancer. Currently only durvalumab and atezolizumab are FDA approved in frontline setting. No benefit when CTLA4 combined with EP or EP PDL1, and this is not as like non-small cell lung cancer. This is the practical consideration on dosing of atezolizumab. In 2019, FDA approved atezolizumab plus carboplatin and etoposide for first line treatment. 3 different dosing schedules approved for atezolizumab: 840 mg, 1200 mg, 1680, and only atezolizumab 1200 mg 3 weekly study in Empower 133 trial. So this is the dosing schedule we know. Practical consideration on durvalumab, all things were same, but dose was for the more than 30 kg, it was 1500 mg 3 weekly plus chemotherapy. In induction time and during maintenance, it was 4 weekly. For weight less than 30 kg, it is 20 mg per kilogram 3 weekly plus chemotherapy into 4 cycles, then 10 mg per kilogram 2 weekly as a single agent. So cross trial comparison, this is we can see the side effects in the side profile. Although in Empower 133 there was 41% were having any type of immune related adverse event. In comparison in Caspian it was only 20%. But rest of the immune-related adverse event, hypothyroid, hyperthyroid, diarrhea, dermatitis, hepatic event, nearby same except dermatitis. That was more in Empower 133. Prophylactic cranial irradiation. 2/3 of patients with small cell lung cancer develop brain mets. PCI is a mainstay treatment of limited stage small cell lung cancer following curative chemoradiation. 5.4% absolute survival benefit at 3 years. PCI now used less often and extensive stage small cell lung cancer, giving conflicting data from EORTC trial and Japanese trial data. Ongoing research and MRI brain surveillance quarterly 3 monthly is reasonable in lieu of PCI for patients with extensive stage small cell lung cancer responding to treatment. So this is the first line combination. Those are approved. Addition of PD-1 inhibition to platinum etoposide chemotherapy significantly improves survival in extensive stage small cell lung cancer. Atezolizumab or durvalumab can be combined according to the FDA approval with the EP protocol. Addition of CTLA4 inhibition to platinum etoposide plus PD-L1 does not add benefit in a small cell lung cancer. Safety outcomes consistent with previous data. PD-L1 inhibition plus chemotherapy is standard of care. So MRI brain surveillance is every 3 months is reasonable if we are not giving PCI in extensive stage small cell lung cancer. Expanding option for second line extensive stage small cell lung cancer with lubrinectedin and biomarker for benefit of immuno drugs remains elusive. Thank you.